Neuro Rehabilitation Principles of Treatment Part 1 Neurocash. Many factors influence the management of patients suffering from neurological disorders. There are many views on appropriate action and treatment, some of which are complementary, while others may conflict to some extent. The greatest conflict occurs when the need for urgent independent function is taken as top priority, when perhaps a little delay in independence could lead to more adequate adjustment of the patient. There are arguments for both sides. It must be remembered that while early functional independence may decongest hospital wards and outpatient departments, this approach inevitably encourages the development of undesirable abnormalities of movement. These are substitutes for those normal activities which have now been temporarily or maybe permanently made unavailable. If a patient's potential is really quite good, given adequate time to redevelop along more normal lines, it may be quite seriously detrimental to him to allow substitute abnormalities to become a habit. Compromise is not always the answer since the result is often that of falling between two stools. Thus, the teamwork between consultants, nurses, and therapists, in addition to other workers, is vital. There is nothing more detrimental to the patient than conflicting views between the team members dealing with his own particular case. The physiotherapist's part in the management will be considered under similar headings to those used in Chapter 4 so that some correlation between the two chapters may be maintained. Aspects other than physiotherapeutic may be mentioned in passing but will not be discussed in detail. Disturbance of afferent information. This can complicate the progress of patient considerably and must always be taken into consideration. Loss of afferent information. This may be local and specific if the problem is a peripheral one, or it may be diffuse if the problem is more centrally placed. Neither case, there is much in common from the physiotherapist's point of view. Injury to the affected area. This is an important aspect in the management of such cases since cutaneous loss, in particular, is likely to make the patient vulnerable to cuts, burns from fire and steam, frictional abrasions from contact with harsh surfaces, and pressure sores from prolonged contact with a supporting surface. All patients with this problem should be made aware of this danger, and it is the job of all concerned with the patient to ensure that he fully appreciates the danger. Obviously, avoidance of injuries is to be encouraged, and the patient should be told to use substitute measures to enable him to detect hazards. His hands are particularly vulnerable if they are involved, since it is hard to avoid injury when the hands are so often used as tools. He must always use his eyes to detect hazards and beware of likely problems ahead of their occurrence so that the complications do not arise. Frictional abrasions and pressure sores can be avoided by adequate padding of areas likely to be subjected to friction and by care over the tying of such things as shoelaces. If there is sensory disturbance in the skin of the lower leg and foot, the application of sheepskin cushions and mattresses for the more heavily disabled is valuable so that the patient is cushioned on air trapped in the wool. Ripple beds and frequent turning are necessary for severely handicapped patient. To some extent, the patient should be responsible for his own safety. He must be warned to inspect his skin for signs of injury and to take steps to relieve pressure whenever possible. For instance, the patient who is confined to a wheelchair should endeavor to lift himself up in the chair by using his arms to relieve the weight and pressure on the buttocks frequently. He will most particularly need to be reminded to do this if he has lost sensation in the buttock region, since he will not then receive the uncomfortable stimuli which would normally encourage him to change position. loss of body image, and rejection of the affected area. This can be quite a difficult problem, and to achieve any measure of success, it is important to remember that we develop a knowledge of body image, of being able to move, touch, and feel objects in close proximity to us, and by being able to touch different parts of ourselves. It will be remembered that as far as the hands are concerned, contact with the face, nose, mouth, and hair is important. Thus, we may be able to prevent loss of body image and rejection of parts of the body by using passive movements which are directed to stimulating some of the more natural activities. Example, taking hands to the face and running the fingers through the hair, allowing the affected area to come into contact with more normal parts of the body and vice versa. The patient may be positioned so that he can see the affected part and have his attention drawn to it frequently. In some problems, this aim of treatment is more important than in others. Permanent rejection is unlikely to occur in the localized peripheral problems, but it is very common in the more centrally placed lesions. If rejection and loss of body image have already occurred by the time the patient is receiving physiotherapy, then the task is much more difficult to deal with. Sometimes exaggerated application of stimuli helps, and heavy compression force repeated with the affected limb in a weight bearing position may help. Constant handling of the area and helping the patient to stimulate normal activities with the affected limb may be of value. Much patience and tolerance is needed in these cases. The use of mirrors is sometimes of value, and of a particular importance is the need to encourage the patient who is showing signs of improving. If the patient is accepting an abnormal position as being normal, this must be pointed out to him and explained in such a way that he understands. He must then be allowed to experience the more normal position with the help of the physiotherapist, who must, of course, ensure that he is safe and secure in his new normal position. Mirrors again may be useful as an adjunct, since the patient may need to use his eyes as substitutes for defective afferent information regarding general position. Even if the eyes are not needed for this purpose, he may need convincing that the new posturing is more normal, since it will feel abnormal to him. Once the patient has appreciated the difference, he must always be encouraged to adopt the more normal posturing in preference to the abnormal. In cases of defects and sensory perception of this kind, in cases where loss of ability to move inevitably encourages the immediate adoption of abnormality, the patient must be treated as early as possible to avoid bad habits of taking hold. For example, a patient who has had a cerebrovascular accident of such severity that he awakes as a hemiplegic starts to develop abnormalities as from that moment. He substitutes and quickly accepts disability on that side of the body, which for a time is virtually useless to him. Very soon it seems normal to carry that half of the body as a passenger and to depend solely upon the non affected side. This will be perpetuated unless some measures to prevent this occurrence are taken very quickly. Disorientation due to faulty information. This can occur if afferent information is not completely cut off, so that faulty impressions are being received. For instance, some patients may have a diminished touch and pressure sensation. If this occurs in the soles of the feet, it gives rise to a cotton wool sensation when the foot contacts a hard surface, and very little sensation at all if a soft surface is contacted. This can make life very difficult for the patient. He may develop the type of gait which involves lifting the knee high and forcing the foot down hard on the floor in order to obtain an exaggerated effect. This method of walking also makes noise which tells the patient when he has landed. He may also have to look where he is walking all the time. In this type of problem, substitution would have to be encouraged, particularly if the disorder is permanent. Such a patient may have to be advised against wearing cushioned soles and heels, since he cannot hear these land on the floor. He may have to wear studded shoes which make more noise than normal when he walks. He would have to be encouraged to use his eyes as substitute sensory organs. As far as possible, his high stepping, exaggerated weight bearing should be avoided since this could cause joint injury. These are special methods of helping the movement problems of such cases. These will be considered under the heading relevant to movement abnormality. Vertigo is another problem associated with faulty afferent information. As was stated in the previous chapter, the patient may feel giddy and nauseated due to disorientation of the position of the head in space. The fault lies usually in the vestibular pathways or in the vestibular organs themselves. Any movement of the head or even of the eyes may make the patient feel symptoms. Impressions from the eyes and vestibular apparatus are so closely associated with each other that disturbance in one can give problems to the other. The patient may have to be trained to rely upon the information he is receiving from his joints and skin and from his eyes, since these are activities. Such patients frequently show a very fixed posture of the head and shoulder girdle because movement of the head is known to trigger off the symptoms. The more unfortunate patient may well have a vertigo in addition to faulty position sense. This makes life very difficult and since substitution information is less available. Many patients with multiple sclerosis show mixed problems, and they may also have defective vision to complicate their problem even further. The method of approach to the movement problem associated with vertigo will be considered under the appropriate heading. Disorders of movement. The average person has a very little appreciation of the complexity of performing an apparently simple function. All the necessary reactions are built in so smoothly that the timing and synchronization of muscle and joint activity escapes notice. Throughout activity, movement occurs against a background of malleable postural tone adjusted to maintain the equilibrium of the individual in all eventualities. In this way, movement flows in a smooth, coordinated, and purposeful manner. Even less appreciated is the importance of afferent information. If there is no appreciation of the position in space, the necessary steps to alter it cannot be taken. Moreover, if inadequate information is forthcoming during the performance of the movement, it can be nothing but crude and wide of the mark since no corrective measures can be taken. For normal function to occur, the nervous systems must be in sound order from the receiving, correlative, and transmission aspects. There must be adequate mobility available in the joints of both the trunk and the limbs, and the muscles must be healthy and able to respond to the activities of the nervous system. It is only under these circumstances that appropriate muscle energy will be forthcoming, giving the common movement patterns associated with normality. The more common movement patterns incorporate a balanced mixture of movements seen in the more primitive mass flexion and mass extension patterns. Primitive mass flexion and extension patterns may be seen in the young child, but even these are more refined than those seen in the patient whose central nervous system is grossly disordered. The tiny child does have some control over his reflex mechanisms, which gives him the ability to modify these effects to some extent. Although the normal child does show a poor vocabulary of movement when compared with a normal adult, he does have the basic foundations upon which to build the permutations and of movement which with which we are familiar in the mature individual. Skill activity is dependent upon mature movement permutation, and therefore mature muscle synergy. Since all human beings are built along essentially the same lines and all required to be able to achieve similar basic functions, certain movement permutations are common to all. During the development of these permutations, the child repeats a movement until it can be achieved with ease, thus illustrating the phenomenon of physiological facilitation. Repetitive use of a neuromuscular pathway lowers the threshold of synapses involved and makes it easier for the pathway to be brought into use. Thus, the pathway is said to be facilitated. Since movement involves excitation of some muscle groups and inhibition of others, it is important to remember that we are facilitating both excitation and inhibition when we facilitate a neuromuscular pathway so that a movement occurs. The word facilitation means to make easy, and it is in this context that the word will be used throughout this chapter. The physiotherapist who undertakes the problem of movement re education in a disabled person is accepting an enormous responsibility. Not only must she be able to detect and assess the degree of and type of abnormality presented, but she must have the necessary knowledge and skill to guide the patient towards normality while recognizing the limitations set by the nature of the disorder. The problem of flaccidity. This may be seen when there is disorder of peripheral system. On referring back to chapter 4, it will be noted that such a state of affairs is usually the result of damage to the motor neurons, pools of the anterior horns, or to fibers passing peripherally from these motor neurons towards the muscles they supply. If all the motor neurons supplying any one muscle or group of muscles are completely destroyed, then the muscles concerned will be completely paralyzed, become flaccid, and show atrophy in which muscle bulk is markedly reduced, offering no protection to underlying structures. If the damage is complete and irreversible, no amount of physiotherapy will restore muscle action. However, if only part of the motor neuron pool is affected, leaving intact those cells which have a higher threshold of stimulation, certain physiological factors may be applied to increase the excitation of effect on the motor neuron pools. In this way, the remaining cells and fibers may be made to convey impulses to the muscles by the process known as recruitment. Similarly, if the cells or fibers of the motor neuron pools have suffered temporary damage, they may eventually regain the ability to conduct impulses to the muscles. This may at first be difficult because they may have a raised threshold of activity. These recovered neurons may also be encouraged to become active more readily by the physiotherapist exploiting her knowledge of physiology so that the use of these pathways is facilitated. In this instance, the physiotherapist has to make use of all the methods she can advise to have an excitatory effect upon the offending motor neuron pool or pools so that each effect can be added together or summated to reach the threshold of excitation. Methods of excitation which are suitable: the use of normal movement patterns. This involves the use of muscles which commonly work with the muscle which is flail. This is value of because this is of value because the neuromuscular pathways commonly used are facilitated during the developmental process by repetition. Volitional impulses are conveyed to the motor neuron pools of the whole pattern. Neurons influencing one motor neuron pool in the pattern are thought to branch and also influence the other associated motor neuron pools. By this spreading of effect, the motor neuron pools of the beaked muscle will receive maximum volitional stimulation. Using the effect of stretch stimulation, the stretch stimulus applied to the muscles involved in the whole pattern will be branching of the afferent nerves, stimulate the motor neuron pools of each other as well as those of their own muscle. The excitatory state of the motor neuron pools, including that of the weaker member of the team will be increased for a brief period of time. It is if to this effect is added volitional effort by summation, the excitatory influence may be enough to cause the lower motor neurons to conduct impulse to the muscles showing weakness. Resistance. This is in effect a kind of continuous stretch applied to working muscle and thus is facilitatory method. The degree of resistance applied should be as great as the muscle can overcome and no greater. In some instances, suitable resistance may be appreciably high, whereas in other instances, it may be as little as frictional opposition offered by the joint being moved. The term maximal resistance is often used, and this must be always related to the available power in the muscle under treatment. The use of traction force. Traction is applicable if the movement pattern to be produced is that of flexion. It stimulates the natural influences upon such movements, which are basically a withdrawal from the pull of gravity. This effect, summated to stretch, resistance, and volition, will further alter the excitatory influence upon the motor neuron pools. The use of approximation, compression through the joint. This is a postural stimulus associated with extension and is thus suitable in any situation in which a weight bearing stimulus could be applied. The extension patterns are most suitably facilitated by the application of approximation. This stimulus, like traction, could be applied to summate with resistance, stretch, and volition. The use of touch. This should be applied over the working muscles and or to the surfaces against which the movement is to occur. This supplies skin stimulation, which acts as a guidance to the movement and facilitates activity in the motor neuron pools. The use of visual and auditory stimulation. A well voiced command facilitates volitional effort. The patient's eyesight is of particular value if sensory information is otherwise a problem. The timing of the use of stretch, traction, or compression and the use of a auditory stimulation is of vital importance. These should all be applied together simultaneously if they are to offer maximum facilitation to the patient's volitional effort. Use is made of both spatial and temporal summation. Misuse of the timing of the application of various stimuli can lead to a reduction in effect. The use of cold, short duration applications of cold in the form of crushed ice over suitable dermatomes can be used to cause excitatory influences to occur at the appropriate motor neuron pools. A time lag is usually necessary between the application of the stimulus and expecting a result. So, consequently, this is a stimulus which can be applied prior to the other methods and it will then be able to add its effect by summation with the other stimuli. The use of brushing. This can be applied to encourage excitation if it is carried out briskly over the inappropriate dermatome. Usually there is a delay in response of up to 20 minutes, so this can be applied prior to other stimuli. The use of writing and equilibrium reactions. These can be applied if the patient is placed in such a position that balance is rather difficult. The postural and equilibrium mechanisms will influence the motor neuron pools of the muscles concerned in implementing the reaction, and if these include the weakened group of the muscles, the influence applied may well have the necessary excitatory effect. To use these reactions effectively, the physiotherapist must have a knowledge of the most common reactions and which patterns of muscles activity are they are likely to stimulate. It is possible to add to this effect by applying approximation through the appropriate limb or limbs and trunk and by commanding the patient to hold while counter pressure is applied in different directions. The use of other parts of the body as a preliminary procedure. When other parts of the body are used, strongly associated reactions can be seen in those parts not being directly stimulated. This may occur because the nervous pathways controlling the movement influence the motor neuron pools of counterbalancing muscles or other associated groups. This is another form of spreading. Thus, if the affected muscle is in the right leg, it would be quite feasible to work the left leg or either of the upper limbs or even the head and neck or trunk first in order to have an irradiation effect upon the motor neuron pools of the affected limb. The use of reversal patterns. Sherrington found that flexor withdrawal reflex was stronger if the extensor thrust reflex preceded it. The phenomenon became known as that of successive induction. This phenomenon also seems to relate to volitional movement. If a movement is preceded by the exact opposite one, the final pattern is produced more strongly. Thus, it is physiologically sound to precede a flexion pattern by an extensor one in order to obtain a stronger flexion pattern. This method would be reversed if it was desired to use this phenomenon to facilitate extension. Emphasizing the weaker team members. When using the above methods to facilitate activity in the weaker members of a muscle team, if it may be found that the weaker member does show activity, this should then be exploited. One method of doing this is to maintain activity in the muscles concerned in the rest of the pattern by making them hold the pattern strongly. The weaker member of the pattern should then be stimulated by stretch and command to participate concentrically repeatedly through a suitable range. In other words, the total pattern is held in a suitable range and movement is only allowed to pivot about the joints controlled by the weaker member of the team. This approach is often called timing for emphasis. Let us take an example. The weakened muscle group is that supplied by the musculocutaneous nerve of the upper limb. Thus, biceps brachii, brachialis, and coracobrachialis muscles are involved. The most appropriate movement pattern for involving these muscles is called the flexion, adduction, and lateral rotation pattern of the upper limb, which would be combined with elbow flexion. In this, the wrist and finger flexors would be used and flexion would be accompanied by radial deviation. The forearm would supinate, the elbow flex and shoulder flex, adduct and lateral rotate so that the hand would be carried towards the face and may progress obliquely across. The scapula would protract and laterally rotate, carrying the upper limb into elevation across the front of the face. Let us suppose that the efforts of biceps and brachialis as elbow flexors are to be emphasized. The patient is commanded into the pattern with the physiotherapist using the appropriate grasp, traction, and stretch stimuli. The biceps and brachialis may be participating weakly and may need help to produce elbow flexion. At the point in range where they offer the most activity, the patient would be commanded to hold the pattern and pressure would be applied to make the shoulder, wrist, and finger muscles hold a strong static contraction, while stretch stimuli and command to bend the elbow would be repeated again and again to get maximum effort out of biceps and brachialis as elbow flexors. As appropriate, the range of the holding of the pattern may be changed until the two muscles are participating well throughout. It may, of course, take many treatment sessions to achieve full range participation. Such an approach may be applied to any muscle group involved in any pattern and may even be used to facilitate a weak pattern of one limb as a whole by making the other limbs or trunk hold appropriate patterns while a weaker limb is encouraged to move through some range. This method of approach is exploiting the spreading effect of branching neurons, which influence their own specific motor neuron pools and those of associated groups. Thus, volition directed to the weaker groups may be more effective since the excitatory threshold of these motor neurons has been to some extent prepared and lowered. The above methods form an ideal way of initiating activity in the weakened groups of muscles and of building on the activity obtained. The second point is very important. When trying to initiate activity, the physiotherapist must be prepared to go to a great deal of trouble to obtain the maximum facilitation and may have to try several methods before a result is achieved. When activity is seen to occur, the physiotherapist must exploit it to the full and try not to lose any ground she has gained. Thus, repetition is vital. The more often the volitional impulses are able to cross the synapses and be transmitted, the more readily can they effect a crossing. Thus, once activity is seen, it must be repeated again and again until it becomes relatively easy to produce. Progress is then made by reducing facilitation and expecting an equally good action to be produced. Once the weakened member has been made active, encouragement should be given to getting it involved in as many functions as are appropriate so that it is no longer allowed to become a passenger but has to participate. These methods are particularly appropriate in the lower motor neuron problem because they make use of strong volitional effort in addition to other stimuli. Since there is nothing wrong with the computer system but only with the external connections, strong volition is unlikely to lead undesirable association movements. In fact, as has been said before, the associated movements may be highly desirable in this case and can be exploited to good effect. When the weakened muscles are participating well in pattern with minimal facilitation, muscle strengthening techniques of a standard variety may be used quite effectively. Progressive gravity free to weight resistance exercise may be given in either in patterns or in a more isolated manner to build up muscle power and endurance. Deep pool therapy may be of particular value. Movement patterns may be quite effectively produced in deep water, and the efforts of the patient may be directed to moving the limbs about the stationary body or the body about the limbs. Pool therapy is of particular value if the patient has large muscle groups involved, when the limbs and trunk may be particularly heavy and unwieldy in a dry land environment. If, however, the muscle weakness is associated with severe reduction in afferent information, as may be the case in polyneuritis, then deep pool therapy may not be so appropriate. Many patients of this type find the weightlessness and lack of sensory information which is associated with the immersion in a deep pool very frightening. They already have sensory loss and do not know their position in space when gravity is being fully effective. If they are then put into pool where the effect of gravity is minimized, then disorientation may be intensified to an alarming level. Each patient must be considered as an individual and assessed and treated to his best advantage. In this section, emphasis has been placed upon the exploitation of physiological factors while using movement patterns. The patterns which are most effective are those described by Dr. Kabat and Margaret Knott and Dorothy Voss. They are of a diagonal nature and include rotational components which are of great importance. The patterns used are described through full range and are most commonly used through full range during certain aspects of treatment. This gives maximum facilitation. Functional daily activities which include these movement patterns through a lesser range are also encouraged in the patient's treatment program. Eventually, it is hoped that the patient will gain maximum participation of the affected muscles without having to have maximum facilitation on their motor neuron pools. It is important to note that the use of movement patterns themselves only offers some help to the affected motor neuron pools. Much more is to be gained by exerting the additional physiological influences which can summate with the patient's volitional efforts to produce the movement pattern. In other words, the patterns are there to be used they are not sufficient in themselves. The techniques described can be applied to straight movements and even to individual muscle actions if the physiotherapist to desire, but they are not as effective used in this way because the patient is really using a pattern of muscle synergy which is new and alien to him, and pathways which have therefore not been physiologically facilitated during their early developmental process. Following this account, it may be helpful to consider one lower motor neuron problem in a little more detail. Let us consider that the patient has had an axillary nerve lesion and the deltoid muscle is at. The problem is one of neuropraxia, and the nerve fibers are showing a very high threshold of activity. To deal with this satisfactorily, the physiotherapist must have a knowledge of the functional significance of muscle and how it participates in many simple daily living activities. Deltoid must be recognized as having the following functions. It is an abductor muscle of the upper limb. Its anterior fibers flex and medially rotate the humerus. Its posterior fibers extend and laterally rotate the humerus. It commonly works with trapezius and serratus anterior to elevate the upper limb. It becomes involved in any functional activities in which the arm is taken away from the side of the body. It counters traction force applied by gravity to the upper limb by supporting the humerus up into the glenoid cavity. It is helped in this function by biceps brachii, triceps, long head, coracobrachialis, and the smaller rotator cuff muscles in addition to the clavicular portion of pectoralis major. It helps to stabilize the shoulder in weight bearing activities and is particularly active if weight is being taken on one arm in the prone kneeling position when it acts as a supporter of the shoulder girdle in the same way as the hip abductors support the pelvic girdle when the opposite limb is taken off the ground. It may be seen working strongly in side sitting, particularly if the body is being pushed away from the supporting arm. It moves the arm away from the body or the body away from the arm if the hand is fixed. It becomes involved in balance reactions when the body is pushed sideways. One upper limb may move outwards to be placed upon a support at the side of the individual while the other may lift sideways in an effort to readjust the overall position of the center of gravity. In both instances, deltoid is involved. It becomes involved in stabilization of the non-weight bearing arm when hand skills are being carried out. It may be felt and seen to be functioning in many fine skills of the hand as a stabilizer and or adjuster of the glenohumeral position. It is involved in turning over movements when moving up and down the bed and from side to side, walking with free swinging arms, carrying the shopping, doing the hair and putting on the hat. In fact, there are so many functions which involve this muscles that this muscle that a book could be filled with an account of them. The physiotherapist must have a knowledge of these functions and also knowledge of the most appropriate movement patterns which may help to facilitate early activity. Probably the most appropriate patterns are the flexion, abduction, and lateral rotation pattern, and also the extension, abduction, and medial rotation pattern. Method of approach: make the patient aware of the reason for his movement difficulties. This can be done by comparing the activities of the affected limb with those of the normal side. The patient may also be shown using mirrors the lack of muscle bulk of deltoid and the trick movements which he is inclined to produce due to lack of participation of the muscle. Make the patient as aware of the muscle as possible. This may be done by using simple methods such as handling the muscle and moving it over the underlying bone using a mixture of kneading and picking up massage manipulations while talking to the patient about the muscle. This incidentally distorts the muscle fibers and may be a start to offering sensory input, which may help to bring about excitation of the motor neuron pools. Light clapping over the muscle may also help in awareness and will stimulate the sensory area in the immediate vicinity, which may be of value. It is also possible to apply electrical stimulation, which will have a similar effect. This will be considered in a later section of this chapter. Start trying to initiate activity. This may be done in many ways, and the physiotherapist should try many before giving up. Some suggestions are as follows: use the normal limb and have the patient in lying position. Give strongly resisted flexion, adduction, and lateral rotation, reversing with extension, abduction, and medial rotation patterns. While doing this, watch for associated activities in the affected limb. It is likely to produce a reciprocal extension, abduction, and pattern of the affected limb, reversing with flexion adduction. There will not be much movement, but a pattern of tone may be noticeable. If this appears to bring about extension, abduction, and medial rotation of the affected limb, then give repeated contractions into the pattern on the normal limb, which is getting the desired associated reaction. This may build up associated activity, then without wasting any time, give flexion, adduction, and lateral rotation as a resisted movement to the affected limb and follow this immediately with a reversal into extension, abduction, and medial rotation. If a result is obtained, give repeated contractions into this pattern. Another possibility would be as follows: have the patient in high sitting, leaning into the onto the hand of the affected side, or in side sitting with the supporting hand being on the affected side. Stroke over the dermatom of C5 and C6 on the affected sides with a piece of ice, and then work the normal limb strongly by giving assisted flexion and abduction with repeated contractions into the pattern. The cold will take about 30 seconds to be of value, so work the normal limb for about 30 seconds and watch the abnormal deltoid all the time. Action of its motor neuron pools is associated is being facilitated because of the compression force to the shoulder, which stimulate stabilizing activity, and because of stimulus of the cold and effect of spreading from voluntary activity of the normal limb. Re-education of the deltoid muscle. If the muscle responds, then make the patient hold the normal limb against a position in flexion and abduction and apply compression force through the shoulder on the affected side. Sway the patient in many directions and ask to hold his position. This may further activate the muscle. There are many other methods which may be used to initiate contraction in this muscle. These approaches are only offered to give a general concept. Follow the contraction which has been initiated into a functional activity. For example, in approach, deltoid was used as a stabilizer of the shoulder while weight was put through the shoulder limb. If the through the upper limb, if the muscle has become active in this way, it may be worth using lateral displacement of body weight to get a balanced reaction and stabilization activity. Have the patient in high or side sitting. Gently pull the body weight laterally using the affected limb and place it in a supporting position. Repeat this sideways sway several times and allow the limb to receive a little compression force from the body weight each time the limb is in a weight bearing position. Gradually take the help of the physiotherapist away and displace the body laterally without helping the arm, watching for deltoid activity as the body sways laterally. Gravity will help the arm to move sideways, but deltoid is needed to prevent overshooting when the weight of the body arrives onto the upper limb. The patient can then be encouraged to push himself back to neutral using the arm as a thrusting tool. If he uses too much trunk substitution, resistance can be applied to the trunk to make help from the arm a necessity. At this stage, it may not be possible to get full participation of deltoid in these activities, but it should be encouraged to participate as much as often as possible. Later progress could involve a short period of maximum facilitation as a warm up method, followed by some further functional activities to encourage easy natural usage. This could then be followed by more specific strengthening techniques. From the moment the patient starts treatment, simple functional habits should be corrected, and as appropriate, functional use should be encouraged. For example, the patient with severe weakness in the deltoid muscle may also have had a painful shoulder injury. He will almost certainly have adopted the bad habit of holding his upper arm strongly adducted into his side, even if additionally it has been supported by a sling. If he has tried to use his hand, he will have steadied his upper arm by even more firmly adducting his arm against his body. This habit is very undesirable since it will not only lead to a stiff shoulder joint but will also actively inhibit the deltoid muscle and so undermine any progress the therapist may hope to achieve. Thus, the habit of clamping the arm side to side must be stopped forthwith, and instead, relaxation either into the sling or just into normal postural pattern should be insisted upon and indeed should take priority over every other treatment measure. Unless this re education of body image and postural pattern occurs quickly, the use of any recovery may be seriously delayed. Similar problems occur when any other muscle group becomes severely weakened, and the physiotherapist must become familiar with the most likely pattern abnormalities which are inclined to be associated with weakness of any of the major muscle groups. A sound knowledge of functional anatomy is essential, and the therapist must expect to go on developing this knowledge for the whole of her working life. In the case of the weakened deltoid, early functional activities can be encouraged as soon as a flicker of contraction is available and the patient has learned to relax the adductors. Relaxed arm swinging when walking is one of the easiest early activities, and this should become established as a habit as soon as possible. Simple stabilization of the shoulder without adduction during the performance of hand skills should be encouraged next. An example of a suitable situation for involvement of the muscle in such activity occurs when the subject leans forward to tie up a shoelace while the foot is on the floor or supported on a stool in front of him. In this example, the effect of the force of gravity is minimal and deltoid needs only to contract very gently to carry out its stabilization function successfully. Balance activities involving the upper limbs may later be added, and active participation in rolling activities and weight bearing on elbow and hands can be expected as the muscle becomes more active. The therapist must make a real effort to help the patient involve the muscle in suitable ways. The patient cannot be expected to do this automatically. He will have had to substitute for deltoid deficiency for so long that he will not be necessarily realize that he is continuing to do so, and neither will he know when or how to involve the muscle without a great deal of help. In the author's view, this part of the re-education program is more important than any of the progressive strengthening exercises recommended, since regular involvement in everyday activities will automatically improve the overall performance of the muscle group as a whole. Strengthening exercises alone do not guarantee involvement of the muscle in daily activities. Specific strengthening could include repeated contractions with emphasis on deltoid in appropriate patterns through different ranges. It could include the use of pulleys and weights as resistance to the pattern of movement, and progressive resistance could be applied. Strengthening could also involve pull therapy, in which the limb is abducted, flexed, and extended using the influence of buoyancy as a support or resistance. On the other hand, the limb could be held stable by the physiotherapist and the patient asked to move the body weight away from the limb, the body being supported all the time by the water. Suspension therapy can be used as substitute for water and can be made very progressive by some enthusiasts. As the muscle gains enough power to lift against gravity, it should require less initial warm-up facilitation and should also be expected to participate in anti-gravity functions. Such things as prone kneeling, changing to side sitting on alternate sides, use deltoid in fairly easy weight bearing activities. Crawling forwards is more difficult because the weight bearing arm has to support the shoulder girdle of both sides and the non weight bearing arm has to lift forward against gravity. Balance reactions may be given in which the deltoid is expected to help in lifting the affected limb sideways and forward in an effort to adjust the overall position of the center of gravity. Overhead arm and hand activity should be encouraged, and light shopping may be carried by the affected limb. Strengthening techniques should be carried out against the force of gravity, and resisted movement patterns may have to be done in the sitting position or some other suitable position so as to involve gravity also. Progressive resistance exercises should include anti gravity activity. Eventually, the patient should not require any preliminary facilitation methods and should be encouraged to participate in sporting and daily activities which will involve the affected limb totally. The patient may do some activities as a member of a group in the gymnasium and have some individual attention, but most important of all, he should be advised on suitable home activities. Eventually, he has to manage his own limb entirely. Home activities are always available and should be exploited. The above outline is not intended to be specific. It is used to give a concept, and there are many variations to any one theme. The physiotherapist is not a technician. She must have a concept of aim, try to fulfill it, and be observant of results so that she can adjust her method. No patient is exactly the same as any other, and no patient can therefore be treated in exactly the same way as anyone else with the same problem. Maximum sensory input in these cases will give maximum motor output. This fact must be exploited in the early stages of treatment and modified as the patient progresses. Electrotherapy in lower motor neuron problem. If a peripheral nerve has been injured in such a way that the pathways will be disrupted for a prolonged period of the time prior to being able to conduct again, it may be advisable to make the muscle contract artificially. This is in order to maintain its mobility against underlying structures and to minimize the rate of atrophy and loss of bulk by promoting the circulation through the muscle itself. In this way, the muscle is maintained in a sound condition until such time as the nerve fibers are able to be functional again. In order to influence as many muscles fibers as possible, it is usual to place an electrode at each end of the muscle belly. Modified direct current is used and trapezoidal pulses of long duration, 30 to 300 millisecond, are given. These pulses are used because they are less likely to stimulate muscles which have a nerve supply. Since they arise and fall slowly, the nerves going to the normal muscle will accommodate to them. Muscles does not have such good powers of accommodation, and since the electrodes are placed over the muscle which has at present no nerve supply, this is the muscle most likely to respond. Shorter duration pulses are not suitable as muscle tissue is unable to respond, and only those muscles which could receive the stimuli via their nerve supply would be able to contract. Apart from keeping the muscles In good condition, electrical stimulation may also help to keep the patient aware of the muscle and its actions. It is possible to use electrotherapy as a re-educative measure when the nerve has repaired but voluntary effort is still having difficulty in producing a contraction. It may prove helpful to use the Faraday type of stimulus to help in the initiation of activity. In this situation, a train of short duration pulses are delivered to the muscle via its nerve supply. The electrodes are therefore placed one over the motor point of the muscle and the other over the nerve trunk or nerve roots. Voluntary effort on the part of the patient is requested at the same time as electrical stimulation is given, and the patient is asked to maintain the contraction when the electrical stimulation is reduced or ceases. This is a method of re education and it can be helpful in certain circumstances. Biofeedback. Biofeedback equipment has now been developed which uses the basic principles of electromyography and can involve the use of surface electrodes applied to the patient by the therapist. This has the value of feeding back to both the therapist and the patient information regarding successful contraction of muscle during a movement activity. The apparatus is neat and compact and can be strapped to the completely mobile patient without any difficulty. The electrodes are placed over the relevant muscle and the electrical discharges issued by the contracting muscle are picked up and converted into audible signals. In this way, the therapist and patient are informed that the muscle is active and success or otherwise can be monitored. The threshold of muscle activity required before a signal is heard can be varied by programming the apparatus to be more or less sensitive to the electrical changes within the muscle. In this way, even the patient with extreme muscle weakness can be informed if his effort has been successful. As the muscle participation improves, the equipment can be made less sensitive so that more activity is required to raise the signal. This equipment is not yet available in all hospital departments, but used skillfully could be of great value both to both therapist and patient.